DMD from Temple University School of Dental Medicine in 1994 and received his certificate in periodontology from the University of Maryland in 1996. He's a diplomat of the American Board of Periodontology and is a clinical associate professor at the University of Pennsylvania. Dr. Levin maintains a private practice limited to periodontology and dental implant therapy in Jenkintown, Pennsylvania. I had the pleasure of first meeting Dr. Levin at one of the dental shows in Scotland. That was a couple of years ago. And, you know, I was just blown away by the presentation. And we certainly enjoyed one or two whiskeys after that as well to get to meet each other or get to know each other a lot better. Without further ado, Dr. Levin, today, title of the presentation is Midfacial Tissue Preservation with Immediate Anterior Implants. Over to you, Doc.
Thank you, David. And again, I'd like to just second your thoughts that everybody around the world is safe and healthy, and that we will be hopefully back to what we love to do sooner rather than later. And so I want to thank everyone for spending some time this morning with all of us to discuss aesthetic implant therapy as it pertains to immediate tooth replacement. And we'll share some new information with you and kind of provide a bit of a primer for what hopefully will be a wonderful conference later this year when we can all get back to congregating again at the Southern Implants Conference in South Africa. And before we start, I'd like to just provide a public service announcement that the new lifestyle that we in the dental community are living in, that after today's session, you should all go outside and take walks and walk your dogs and take a break from the webinar onslaught that has replaced our normal way of life. So what are we concerned about today, and what is the topic? And today, really what we're going to talk about is diagnosing and treatment planning our aesthetic tooth replacement cases so we don't run into some of the complications that we've all seen, whether it's patients coming to us for second opinions or patients coming to us out of the jump with a tooth that needs to be replaced, and to develop strategies so we don't have these stressful moments where we have to address things that we probably could have avoided from the beginning of treatment. And so our challenge is to provide stability, implant stability, prosthetic stability, and aesthetic stability over time, where when a patient's treatment is completed, that they remain stable for years to come. And truly one of the keys to this stability, as we talk about the title being that marginal soft tissue stability in the anterior zone, is when we see this type of stability of the soft tissue margins, that we have to respect that what's beneath that soft tissue plays a critical role in maintaining aesthetics for the long term, which also leads to the health of these implants. And about 5 years ago, Dr. Sergio Rubinstein and Dr. Lou Rose and I put out a paper in the Aesthetic Journal talking about some of these principles that we need to keep in mind before we start immediate tooth replacement therapy in the maxillary anterior region. And the question that we always seem to discuss here really is, once the implant is placed into an extraction socket, is we have a gap. And one, do we want that gap? And two, how do we manage that gap? And the literature has certainly shown us that we do want to provide a significant amount of space between the implant and that facial hardened soft tissue region in our extraction sockets. And then the next question that always seems to come up in these conversations that we have amongst colleagues is, how do we manage the gap? Do we need to graft these sites in terms of bone grafting, soft tissue grafting, and so forth? And I think it's very important to point out, with of course the exceptions that we all see in our practice, is that the natural healing process will result in loss of both the height and the horizontal dimensions of the alveolus once the tooth is extracted. And that will not change if an implant is placed into an extraction site. And we can go back in our literature, and Uli Grunder published a paper 15 years ago showing us that we really need to preserve at least 2 millimeters, if not more, of facial bone around these implants if we're going to have this long-term stability of soft tissue, which almost always lends itself to some form of bone augmentation. And we know from Chen that most of these facial plates of bone in the anterior maxilla are very thin. And with a flapless extraction alone, at 8 weeks, we lose about 1.5 millimeters of height of that bony crest, which can play a critical role in maintaining our soft tissue levels as well. And the other issue that we sometimes deal with is, do we have to graft? Do we have to approach these situations from a regenerative perspective? And a lot of that comes down to the thickness of the facial plate of bone and soft tissue phenotypes. And we know from the literature that the vast majority of maxillary anterior sites present themselves with very thin, often poorly vascularized facial bone. And Joe Kahn's group showed us that when a tooth is extracted, an implant is placed and immediately temporized, if no augmentation is performed at all, the gingival recession will continue well beyond that first year after active treatment. And this is where some of our early successes become late failures in terms of aesthetics. And even when bone grafting is done in these cases between the hard socket walls or the bony walls and the implant, we still can see some loss of bone and some soft tissue recession over time. And Daniele Carteropoli showed that recently in a follow-up that by grafting this zone, we can preserve about 93% of the horizontal dimension, but that all of these sites are thin and that augmentation plays a critical role in maintaining that three-dimensional morphology of the alveolus after a tooth is extracted and an implant is placed. And so for me, an era that really changed things was when the dual zone grafting concept came about with Dr. Tarnow and Dr. Chu, where they were able to show that by grafting the immediate place implants, not only within the bony walls of the socket, but up to that soft tissue margin and temporizing these sites, that not only was the horizontal ridge best preserved, but there was less gingival recession and that soft tissue thickness was increased to where it was pre-treatment. And if we look at the importance of that soft tissue thickness, we know over the last decade from Thomas Linkovicius' group that in areas where that mucosa is thin, basically a 2 millimeter cutoff, there will be more hard tissue or marginal bone loss seen radiographically. And this should not come as a surprise because we know, going back to the Scandinavian classic studies in the animal model, that biologic width will always prevail. And when there is thinner soft tissue, the bone will then be what costs us in terms of marginal bone support, because biologic width will always prevail. And no matter what we do to try to counter this, if we don't have thick enough soft tissues, biology will always, always win out. And the other important aspect of thickening the soft tissues, now I'm a periodontist and I don't restore the implants, but my referring base, my restorative dentists certainly want to achieve the highest level of aesthetics. And if I can provide soft tissues that are at least 2 millimeters in thickness, then my colleagues have a much better opportunity to mask that shadow caused by abutments below that gingival margin around these implants. And so this leads us to something called the dermal apron technique, which I first published in 2016 in the Journal of Aesthetic Dentistry. And this came about because I would, like most of you who are performing this type of treatment, was using conventional methods of increasing the thickness and volume of the mucosa with subepithelial connective tissue grafts. But certainly we cannot ignore the morbidity associated even with single incision, minimally invasive harvesting of these grafts, that we have a second site now. And this increases the time, the cost, and like I said, the morbidity for these patients. And is there an alternative? And so what the dermal apron technique does is it uses a dermal allograft, and the one that I use the vast majority of time is one of about 0.4 to 0.8 millimeters in thickness as a substitute for an autogenous connective tissue graft. And this was really an extrapolation of a technique that I was using that I was very fortunate to publish 5 years ago in the International Journal of Periodontics and Restorative Dentistry, where we were using a dermal allograft for two purposes. One, to serve as a membrane over a particulate bone graft for immediate implants, anterior and posterior. And in the same way that Linkevicius group was using these in healed sites, we were using it in immediate sites to try to thicken that soft tissue, which will better preserve our marginal bone. And so the dermal apron technique, I will walk you through this. I will get into this in greater detail in Zimbabwe, hopefully later this year. Hopefully many of you can join us. But to walk you through this, the anterior tooth is extracted in a flapless manner. Minimal trauma is hopefully elicited during this extraction. The implant is placed to the palatal aspect, preserving that gap space. And then we perform a dual zone bone graft, very similar to the way Dr. Parnell and Dr. Chu advocate, except that we use a cortical allograft versus the cancellous allograft, and combine that with a xenograft at about a 4:1 ratio in the same manner all the way up to the soft tissue margin. And at that point, we take our soft tissue allograft that we mentioned and we trim it. We use a disposable tissue punch to pierce the allograft at a diameter slightly narrower than the diameter of the abutment that we're using to make our one-piece screw-retained temporary crown. And it's important in terms of orientation that the basement membrane side, which will not absorb blood and will basically stay relatively white, is adapted as so that when the apron is adapted over the provisional crown, it is facing outward. And then once that provisional crown is seated, we take a radiograph to confirm that the abutment is completely seated within the implant. The lamina propria, or connective tissue surface, which will absorb blood and stay pink or red, is now facing outward. And that is what will then be tucked into a small subperiosteal pouch in contact with the overlying periosteum to allow it to integrate over our dual zone graft. And then we'll usually use just a resorbable figure-8 mattress suture for gentle compression. We don't want to compress too tight and risk necrosis of the overlying tissue, but just gentle compression. And you can see here how the dermal apron technique is performed. Now, this is one of the original dermal apron patients that we treated 6 years ago with a maxillary canine that was failing and required extraction. We placed an implant at a diameter that would maintain that gap. And then we perform our dual zone bone grafting, as you can see on the left, and we fabricate with a modified provisional abutment, a provisional crown. And on the right, you can see the dermal apron. And so this is how the patient leaves the office the day of extraction of her maxillary left canine. And this is at 10 months after surgery was performed with her final crown in place. And you can see the radiograph shows marginal bone has been maintained. We have a good aesthetic outcome for the patient. But what is the long-term success of this procedure? Well, this is 6 years after surgery. And at 6 years, you can see that we've maintained marginal soft tissue levels and marginal bone levels. And so we've been able to accomplish thickening that peri-implant soft tissue and maintaining an aesthetic outcome for this patient using the dermal apron technique. And so I was encouraged by my colleague, Steve Chu, to make some measurements. And we published this 2 years ago, looking at the changes in peri-implant soft tissue thickness using dermal apron with a uniaxial or straight implant. And so what we did was we scanned the models of the soft tissue replicas that the dental lab returned to the restorative dentist to deliver the final restoration, and we measured tissue thickness at 1, 2, 3 millimeters apical to the gingival margin. And what we were able to demonstrate with this technique is that the dermal apron technique significantly increased the thickness of the soft tissue at all 3 levels compared to their ungrafted, immediately restored cases in their part 2 of their dual zone paper. And the next issue that we have to overcome here is when we're working on aesthetically replacing teeth immediately in the maxillary anterior region, is that surgically we know that if an implant is to be placed along the long axis of the restoration, we're frequently dealing with a facial or incisal position of that abutment screw, number 1. And number 2, when we look at David Cochran's work, that we run a very, very high risk of perforating that facial bone in the apical region. And so one of the solutions that industry has come up with for us to maintain a screw-retained solution is with an angle correction implant. And certainly they have a place and they play a role here in avoiding some of the complications associated with cement-retained restorations. But we've seen now in recent papers that these types of abutments have some issues as well. One being that it is much more difficult to achieve and maintain that tightening torque of the abutment screw. And studies have shown a very high number of these abutment screws have a risk of a catastrophic fracture, and actually twice as many as those abutment screws compared to those in a straight abutment on a benchtop study. Another issue that we look at from a biologic standpoint is that this angle correction is always going to occur above or coronal to that facial bone. And does that put undue pressure on the soft tissues and increase our risk of gingival recession? And we know from going back a decade that we have critical and subcritical contours of restorations, whether they be provisional or final restorations, but that undue pressure above that bony crest can compromise the aesthetics of these cases. And so we need laboratory technicians like the ones that work with Steve in his office to be very cognizant of the subcritical and critical contours of these restorations if we are going to maintain soft tissue levels. Now, another solution that I think is a much better solution biologically is to correct the angle of that abutment screw within the implant itself, which is called the coaxis or subcrestal angle correction implant, which you can see here, where the implant can be placed at a level in really with the direction parallel with the incisal edge of the future restoration. And with a 12-degree correction, we still can maintain screw retention. And Howe showed us that the offset between the root and the clinical crown of maxillary anterior teeth ranges about 8 to 12 degrees. So this 12-degree correction is really perfect if we're going to place the implant along its long axis of the restoration and yet not risk these apical perforations that David Cochran's group has showed us. And this implant is not new, and this concept is not new. We've seen up to 5-year follow-up studies with very high success rates of this coaxis type of implant. And something to consider here is when these implants are placed along the long axis of the restoration. And here a benchtop study recently looked at just 30 degrees, which is not uncommon for these cases to be placed, that by using that 12-degree angle correction, we really only have an 18-degree offset and significantly better maintenance of that screw torque compared to a straight or uniaxial implant being loaded 30 degrees off axis. And so what we did in the study that is online now and will be in the International Journal of Periodontics and Restorative Dentistry later this year is we repeated the dermal apron study, with the only variable being that we now used an implant with this subcrestal angle correction to measure soft tissue thickness. And so, like I said, the protocol was exactly the same. We were performing a flapless immediate placement, dual zone grafting with our 4-to-1 ratio composite of allograft and xenograft, dermal aprons with immediate provisional crowns out of occlusion. The only variable was this coaxis implant that has this variable platform shift, which we'll talk about on the facial aspect. And so if you see these types of these coaxis implants here, we have a greater distance from the outer diameter border of the implant to where the abutment connects to the internal portion of the implant, making it a much greater distance or a larger platform shift. And so this was one of the patients treated in part 2 of the study. And you can appreciate here that in the majority of cases, as Joe Kahn has taught us, that we have a very robust area of bone palatal to the anatomic extraction socket in the majority of these anterior situations. And so here we see the extracted tooth. We have a direction indicator with a 12-degree angle correction, so we can appreciate not only our mesiodistal and coronoapical osteotomy preparation, but we can also have an appreciation of where our abutment screw will be projecting through the provisional and final restoration. And so this is the coaxis implant in place, a 4mm by 13mm length implant in place with primary stability. And we're performing dual zone grafting and fabricating a provisional crown on an analog, using the crown from the extracted tooth as a reference in terms of contours. And so we perform the dermal apron, as you can see, and here you see that the basement membrane surface of the dermal allograft visible, which maintains its white appearance. We tuck the apron into a subperiosteal pouch. And this is at 7 months after surgery when the patient returns from Florida. And now we can use a non-surgical approach to actually cause a bit of apical migration of that facial tissue, because we have very thick, healthy marginal tissue around this implant, and radiographically the bone levels are on top of the implant platform and maintained on the adjacent teeth for papilla maintenance. And so this is the day of insertion of the final restoration and a porcelain laminate that the restorative dentist treatment planned on the lateral incisor. But we've been able to maintain good tissue topography, thickness, and the patient can have a screw retained restoration. And what we found to be very important in this part 2 of our study was that the soft tissue thickness, 2 millimeters from the gingival margin, was 5 millimeters thick, which is a robust, healthy soft tissue that we feel confident in terms of helping to maintain facial marginal bone and marginal soft tissue levels for long-lasting aesthetics. And I don't think this would have been possible had no augmentation been performed at the time of surgery. And so you can see where we started, and we had a thinner, friable type of marginal gingiva around this tooth. And now we have a much more aesthetically pleasing outcome with very thick, robust marginal gingiva. Another patient in the study, here one of a more thinner, friable type of periodontal phenotype, heavily restored, and she fractured again the left central incisor. And so again, the directional indicator to walk you through the process, 12 degrees, so we can appreciate where the screw access will be anticipated to be. The implant is placed again, primary stability, and following the guidelines of people such as Lyndon Cooper, that we want to keep that implant platform 3 to 4 millimeters apical to the facial gingival margin. And again, we perform dual zone grafting, and we use our shell to fabricate a screw retained provisional restoration, perform our dermal apron, and this is how the patient leaves the office the day of extraction of tooth number 9. With a screw retained provisional crown, slightly in buccal version to avoid any occlusal contact, and the patient has been advised in terms of not using this tooth for function for at least 8 to 10 weeks. And when it was time for the final restoration to be made, the soft tissue model was scanned, and we achieved a thickness of almost 2.5 millimeters of soft tissue volume on the direct facial of this implant. And this is 16 months after surgery. And I think you can appreciate not only are things stable, but we've probably converted tooth number 9 to a medium tissue phenotype compared to the thin phenotype that we started with, which you can appreciate when you look at the soft tissues around the adjacent central incisor. And yet radiographically, bone levels look as if bone is still sitting on top of the implant platform. And so if you look at where we started and where we are almost a year and a half after treatment, this is becoming a predictable, successful way to replace teeth in the maxillary anterior region for us. And I think one of the critical factors for this type of treatment is this increased platform switch on these coaxis implants compared to the straight implant. And this is something that is referred to as a variable platform switch. And I think the more that we start looking at this, the more we can appreciate the role that this platform switch on the coaxis implant plays in us achieving and maintaining healthier and more robust hard and soft tissues. And so part 2 of this study, as I mentioned, is available online now and will be in print this year, showed us that compared to the 15 consecutive cases in part 1 with a uniaxial implant, this coaxis implant being the only variable at all in our study came with about 1 millimeter increase in soft tissue thickness compared to the uniaxial implant, which I think have to attribute to that variable platform switch because it was the only variable that we looked at. And importantly, when we compared periodontal phenotypes, both the thick and the thin phenotype patients achieved greater tissue volume with this subcrestal angle correction implant compared to a uniaxial implant. So maybe this was not the intention of the coaxis implant in terms of increasing soft tissue thickness, but more towards enabling screw retention. But yet an offshoot of this is that we are now able to produce a much thicker soft tissue just using this variable platform switch. And one of the other findings that we had here, which I think is going to have ramifications much further down the line, was that with part 1 of the study with uniaxial implants, 12 of those 15 cases were cement retained crowns. And in the second part with the coaxis implant, 12 of the 15 were screw retained, and probably could have been 14 of these cases, except for some of the habits of some of the restorative dentists still like to use cement restorations out of habit. But the ability to provide that possibility for our restorative colleagues of allowing the screw retained retrievable type of restoration in the maxillary anterior region, I think is a really nice value for using this type of implant. So we talk about implant positioning within extraction sockets. And we know that we don't want to use a wider implant that we may associate with giving us better primary stability because of the proximity of these wider implants to that facial plate of bone. We want to preserve that gap. And so we're going to talk about an implant now that has an inverted body design with that subcrestal angle correction as well, that has a smaller top, which allows us to achieve the primary stability that we see with wider implants, but yet a narrower top to preserve and give us the ability to graft coronal hard and soft tissues. And so we know that osseointegration is really not the goal. We expect osseointegration in the vast majority of cases now, but what we want is a smaller implant towards the palatal aspect to give us the ability to preserve and maintain the hard and soft tissue volume. And in a recent paper by Steve Chu and Joe Kahn and Ernesto Lee, they looked at implant position and its effect on how provisional and final restorations need to be contoured below that soft tissue margin. And that plays a huge role in terms of how we proceed with our cases and how predictable aesthetics can be achieved. And so we have this macro hybrid implant that I will discuss to some point now, but certainly much more in South Africa, But if we look at some of the virtues of this inverted body implant design, we see one, that because the top of the implant is a narrower cylindrical form, we maintain that gap space between our facial tissues and the implant. And because it is narrower, we also provide a greater space between adjacent teeth and this implant, which is critical in terms of preserving papilla height and maintaining aesthetics. And with that 12-degree subcrestal angle correction, we can avoid these apical perforations with a uniaxial implant that would be coming through the incisal edge, otherwise mandating that we have a cement-retained restoration. And with this implant, just to go over this briefly, we have about a 60% apical portion, which is a wider diameter tapered implant with more aggressive threads that allows us to achieve a higher insertion torque than is commonly found with normal tapered implants or cylindrical implants. And yet we have about a 40% coronal aspect that is a less aggressive thread pitch and a subcrestal angle correction as well. And this implant recently has been shown, compared to normal tapered implants in a benchtop study, to achieve higher mean insertion torques than a conventional tapered implant. And in the cadavers also, it was shown in the same study that that facial gap was able to be maintained because of that narrower coronal portion. And so there are a lot of things to really like about this implant design for those of us performing immediate tooth replacement therapy in the maxillary anterior region. Now, this was one of the first patients I treated with this inverted body design implant, or the Inverta, for a woman in her early 30s who had external root resorption of her maxillary left central incisor and was very upset at the prospect of going even a short period of time with a removable prosthesis while things were healed. And so we planned for her to receive one of these inverted body design implants for immediate tooth replacement. And so you can see the extracted tooth with the significant resorptive lesion found on the palate. And again, that 12-degree angle correction guide pin showing where the screw retention will be possible with the implant placed to the palatal aspect, avoiding any risks of facial perforation apically. And I mentioned to you before, we're using these implants in a manner where the drilling or the osteotomy preparation has an incisal pathway. And so initially this feels kind of strange when you're thinking about a screw-retained provisional crown, but what I found was once I took that leap of faith that we were going to be okay and we were going to have screw retention, this has become now second nature. And again, very important to point out that with this subcrestal angle correction on these Inverta implants, we still have a variable platform switch. We have a greater distance from the internal connection of the abutment to the outer diameter of the implant on the facial aspect for these cases, which we are then capitalizing on with our aesthetic cases. So the implant is placed here at an insertion torque of 45 Newton centimeters, which for those of you who do know me, know that I'm not an aggressive surgeon when it comes to insertion torque, but this 45 Newton centimeters certainly falls well within the realm of what most people would feel comfortable advocating for an immediate temporary restoration. The implant has a palatal bias. And then we can go and perform our dual zone grafting, as we've already mentioned, and fabricate a screw-retained provisional restoration using the natural tooth as a guide as far as contours are concerned. And dermal apron is performed, and this is how the patient leaves the office the day of extraction of tooth number 9. And radiographically, you can appreciate that because the implant has a narrower top, we're able to maintain a very comfortable distance from that lateral incisor, so we can feel better about knowing that the peak of bone on the mesial aspect of tooth number 10 will stick around and maintain our papilla height. And so this is at 6 weeks post-op. We take our first radiograph, and certainly things are looking healthy. We have thick, healthy mucosa, and radiographically, we have no change in marginal bone levels. So at 10 weeks, we bring the patient back and we disconnect the provisional restoration to check our stability. And we see almost a 10-point increase in ISQ values, which we know a 10-point increase results in about a 50% reduction in micromotion. So we know what's going on here around that coronal bone chamber that we see around the implant. Now, if we were going to place our traditional tapered implant, the widest portion of that implant is at the most coronal aspect. And so we run the risk of encroaching on that marginal bone adjacent to the teeth next to the implant, and that could cost us a papilla or part of the papilla. But by using this inverted body design, we maintain space that we can graft, and we can maintain that safe distance that we know is critical for maintaining the papilla height. And so this is the soft tissue model that was sent to me from the restorative dentist. And you can see that 2 millimeters from that gingival margin, we have almost 3 millimeters of soft tissue thickness, which we know is critical to have at least 2 millimeters if we're going to mask the shadows that come through from underlying abutment material. And so this is the day of delivery of the final screw retained restoration. You can appreciate that the marginal bone levels have basically remained unchanged around the implant and the adjacent teeth. And many people will sometimes, when they play guess the implant game, will look for that distal papilla to see if it's shorter. And if you compare the papilla between teeth number 7 and 8 and number 9 and number 10, we don't have a great disparity here. And I think that this implant design not only lends itself to preserving that facial hardened soft tissue, but the interproximal hardened soft tissue as well, much better than what else we have on the market today. And so what we're going to be looking at in the future, and I will be presenting this in South Africa, is part 3 of the study where we are performing dermal apron procedures and making soft tissue measurements again to see if we can exploit that narrower top combined with the variable platform switch to hopefully, and what I think we're starting to see is even thicker soft tissue than with that subcrestal angle correction alone, because now we're combining variable platform switch with a narrower implant top, greater space between the facial wall and the implant itself. So please stay tuned for part 3 of this study. Now, certainly being a student of Jerry Bowers, I don't like using anything in my practice on my patients that isn't supported in the literature. And what we've seen over the last few years is an increasing growing body of evidence supporting this inverted body implant design, not only in terms of not causing negative changes in the trabecular bone for immediate sites regarding pressure necrosis, but tissue preservation and pink aesthetic scores and white aesthetic scores. And so I've been very fortunate to be part of some of this growing body of evidence, but certainly very well-respected researchers have shown that this implant not only works, but may be a huge step in the right direction in terms of achieving and maintaining aesthetic outcomes for immediate tooth replacement. And as I mentioned, I was very fortunate to be asked to be part of this registry of the American group looking at this implant. And so we had a set protocol here where we were performing flapless immediate implant placement, all in type 1 sockets, healthy sockets. They all had this 12-degree subcrestal angle correction, dual zone grafting with cancellous mineralized allograft as Dr. Tarnow and Dr. Chu perform, and immediate provisional crowns or custom healing abutments to support that soft tissue and act almost like a socket seal over that bone graft. And so this is one of the registry patients I treated, another central incisor with a fracture after many years of endodontic treatment. No crown was placed on the tooth. Again, flapless extraction, maintaining the gap around the implant because of the narrower top. We perform a dual zone, and this we're working in a team approach with my colleague Brian Wilk. So we perform our dual zone, we take an impression, we place a healing abutment, And then the patient takes the model from that impression and heads right over to the restorative dentist Brian's office for the provisional crown, which he can fabricate on the tabletop and keep it out of occlusal contact. And what we see at 3 months healing is we've maintained bone. If you look at that peak of bone between the lateral incisor and the implant, that is critical for maintaining the papilla, and the soft tissues have been well preserved, as you can see. So this is at about 3.5 months after surgery. And you can see here we have a very robust, thick, soft tissue to frame that final screw-retained restoration. And we've maintained ridge contours as well. And you can see radiographically that we haven't lost any marginal bone. And so when we look where we started and where we concluded, not only is marginal soft tissue maintained, but interproximal tissue is relatively well maintained. And so this implant is really changing the way we think about immediate tooth replacement, because it lends itself so well to the preservation and augmentation when necessary of the hard and soft tissues. Another registry case here of a patient who had fractured tooth number 8, as you can see on the right-hand side. And we don't have an abundance of bone palatal and apical to work with here. So the tooth is extracted. Again, our 12-degree angle correction guide pin is in place. We have good insertion torque. I have started to come around a little bit in terms of using some of these higher insertion torque values because we're working in trabecular bone, and good implant stability. And so we maintain our gap, we perform our dual zone grafting here, and fabricate a provisional crown that is placed out of occlusal contact with screw retention. And this is the day of surgery. And you can see here at 6 weeks that we've maintained healthy hard and soft tissue volume and levels, and at 10 weeks, we see a slight increase in terms of implant stability based on ISQ, and we have very thick soft tissue framing that provisional restoration. So this patient is then referred to Dr. Michael Weiss, the restorative dentist, who fabricates a wonderful screw-retained restoration. And when we look at the soft tissue model, again, we're at 2.75 millimeters of tissue thickness, which we know is adequate in terms of masking any shadows coming from the underlying components. And this is the final screw-retained restoration on number 8. And Michael did a beautiful job repairing that fractured porcelain on the other central incisor for aesthetics. And so you can see where we started and where we finished treatment here for this patient using this inverted body design implant. And so to conclude, I would just like to say that we have many, many things that we have to think about before we ever pick up an instrument. And so diagnosis and case selection is a critical aspect of treatment before we ever start. And then we have so many factors in terms of three-dimensional implant positioning, performing the right type of surgery with the right type of implant, appreciating the physiologic changes that occur after an extraction, and taking measures from both a surgical and restorative aspect to prevent these changes and optimize our results for the long term. It all comes down to biology, and we have to respect this before we ever pick up an instrument. And if we think about using the right tools for the right job, we can achieve predictable success in immediate tooth replacement therapy. And with that, I want to thank you very much. And I don't know, David, if you want to.
Yeah, thanks, Dr. Levin, for an awesome presentation. Very detailed and in-depth. Yeah, really appreciate it. Thank you. I think there's a few questions at the bottom of the screen there. I don't know if you want to run through those, and please, you know, the audience, you know, any questions, go for it.
Sure. Okay. Well, one question was, what is the minimum bone to be sufficient on the lingual wall if I prefer 2 millimeters on the facial? Well, I think in general, we want at least 2 millimeters of bone circumferentially around the implant. And so that would be something that we would like to achieve on the palatal as well. Now we know from a recent animal study that implants that are tilted to the lingual will typically be a little bit deeper in a coronal apical position lingually. And using our three-dimensional radiographs or cone beams gives us an opportunity to appreciate not only that facial wall, but also the palatal wall. And are there times that we graft a gap between the implant and the palatal wall? Absolutely, positively, yes. But we'd like to maintain at least 2 millimeters of bone, 360 degrees around the implant. Another question was regarding the dermal apron on the lingual and facial. It doesn't fold because we trim it properly and we make measurements and we perform a subperiosteal reflection about 3 millimeters beyond the crest of bone. And with special instrumentation and being a periodontist and being used to manipulating soft tissue grafts, there are times that we'll use a suture if we have more of a type 2 socket, where we're using the dermal apron in a slightly longer length to help us position the dermis so it doesn't fold on itself. Let's see, my good friend and colleague Sergio Rubenstein asked if I ever use a soft tissue graft when the tissue is thin prior to the implant being placed, or is it better to manage with the dermal apron? And Sergio, I can certainly tell you that there are still times that I will use a subepithelial connective tissue graft or an autogenous tissue graft. Typically these are the extremely thin periodontal biotype or phenotype types of patients. If we have some pre-existing recession, one of the caveats of the dermal apron technique is that it really does need to be 100% below that soft tissue margin if it's going to incorporate. If a portion of the apron is left exposed to the oral cavity, it will not revascularize and become part of the soft tissue. Now, soft tissue may migrate over that over time, but that is certainly not as predictable or forgiving to a connective tissue graft. So there are certainly times we still use it, but I would, if I had to off the top of my head give a percentage of times that I use a connective tissue graft, it would be less than 5% of the time. A question about using piezo surgery. I use piezo surgery frequently. I typically don't use it in these maxillary anterior immediate tooth replacement cases, unless we have something like an ankylosis that we need to navigate around the tooth to be extracted. But typically I use periodontal geared instruments in terms of periotomes and exotomes to try to gently luxate and separate the PDL. Let's see. Now, a question about confining the use of the new implant to maxillary anterior. I have used this inverted body implant in numerous sites. In bicuspids, I have used it. I certainly don't have time to go into all the different applications of it, but we have situations in mandibular bicuspids and even sometimes canines, but mandibular bicuspids come to mind where we have a deep lingual concavity. And, looking at a two-dimensional x-ray, we may feel like we have room apical to the extraction socket for osteotomy preparation. But if we look cross-sectionally, that could turn into a catastrophic outcome if we just went into the base of the extraction socket. And so I have actually turned around the osteotomy preparation to emerge through the lingual cusp of the tooth to be extracted and use that 12-degree in a 180 and actually have the variable platform switch on the lingual, which allows us to get the implant into more bone apically to achieve primary stability without perforating that lingual concavity. So Primarily, this is an implant that has great application in extraction sockets in general. The diameters, I think, are going to be made wider over time. And as that happens, the applications in more posterior sites will probably increase. In terms of Siebert Class 3 sockets, I think what I'm thinking with that question is, are we talking more about the Ilian Class 3 sockets? And the answer would be no. If we have significant hard and soft tissue recession on the facial aspect, I probably am extracting the tooth and either allowing soft tissue maturation or using a connective tissue graft over a particulate to rebuild the site first. And let's see what else we have. Thank you. And I appreciate the comments and compliments from some of the people that were very kind to join me. Let's see. How do I feel about socket shield technique? And this is a good question. And to be totally honest, I do not use the socket shield technique. I respect the people that do. And I think that some of the people out there that have been using it for a long time are doing a wonderful job and accomplishing great things. I mean, Marcus Hertzler's group has done a great job. Howard Gluckman's group has done a great job. But I think it's a very technique sensitive procedure. And I think you have to be very comfortable using it. And I think if you are, I think it's great. I mean, I think this Inverta implant lends itself to the socket shield because it provides more room for the shield to still exist. For me personally, I've been able to achieve the results that I would consider to be comparable to those who are presenting wonderful results with socket shield using dermal apron. And so I just haven't gotten into it, but I don't have anything negative to say. I have seen a few complications in terms of socket shield performed by others, but I don't know what the expertise that these people that were performing the procedure had. And so I don't want to make a broad statement on it. How do I feel about socket shield leaving a buccal portion of the tooth to prevent recession? Again, I mean, I think one of the things I will say about socket shield is if we have these patients with a very thin periodontal phenotype, I don't know what the ramification would be about performing the kind of reflection, whether it's partial or full thickness, to place either a connective tissue graft or a dermal apron, and does that run the risk of dislodging the socket shield towards the end of the procedure? I don't know. I don't know that anybody has really looked at that yet. But I understand the concept and appreciate the concept. I just can't speak about it personally. Let's see. One of the slides showed an infected apicoectomy. And was there an issue with this? And that's a good question. And I actually anticipated that question after showing that slide. And one thing to take in mind is that that was more of a chronic infection. One, there was no suppuration, but because we're really using that triangle of bonus, Scott Gans likes to call it, palatal to the extraction socket, that the osteotomy is basically not going through the infected portion of the extraction socket. Now, I thoroughly debride all of the extractions with ultrasonic instrumentation as well as manual instrumentation, and then treat it with empirically a slurry of doxycycline for 3 minutes, followed by a copious sterile saline rinse to try to remove locally as much of the infection as possible, and also systemic antibiotics. But I will say that if the implant was going right through the base or the apical portion of the extraction socket, I may have some reservations with this, but I don't, because we're typically not using that portion of the extraction socket to play any role other than to fill with bone after the procedure is performed. But it's a very, very good question. Let's see. Would I add the use of the Ashburn the densibers, I'm assuming that's what it means, to increase ISQ. No, I know there's a big movement towards this osteodensification. And again, I have some colleagues and friends that are in favor of it and report wonderful results. What I have typically found, especially with these Inverta implants, is that they are really designed for primary stability. I mean, I typically don't undersize unless the bone is extremely soft in my hands. And I am not running into an issue with not achieving primary stability with these implants. I see some of the histologic papers coming out on this osteodensification, and maybe that is where we're heading. But at this point, I'm not seeing a need for it using this type of implant. Now, if you are in the camp of over 100 Newton centimeters of insertion torque being your sweet spot, I mean, by all means, you may want to use that. I know Costa uses it in Greece and really loves it. And I think if it works well in your hands, that's great. Let's see, Michael Block. I see you seem to be doing fewer dermal aprons when you graft. Okay, Michael, so that actually was, I was showing some of the registry cases, and part of that registry where all of the people that were part of it got together in New York before we started the registry, and we had a set protocol where we were only doing dual zone grafting. I will tell you that my registry cases are completed, and I am back to dermal aprons on all of these cases. We measured the soft tissue thickness on many of my registry cases, and we achieved good results. And I think in many cases, it's enough. I think there are some cases with the thinner phenotypes in particular where I personally think we would do better with the dermal apron in terms of maybe achieving even thicker soft tissue, but that's a friendly competition between me and the boys in New York. I would never question their results because what they've done has changed everything. And I think dual zone is the way to go, whether you put a dermal apron over it or not. But my dermal apron has gone back to my go-to for 100% of these, or 99% of these, unless we're using a connective tissue graft. But I would also say that with dermal apron, we use a cortical mineralized allograft with a xenograft. And I think some of the reports of bone sequestering through that soft tissue with a dual zone, and that's really why the cancellous bone incorporates better. Because the dermal apron not only thickens the soft tissue, but also serves as a guided bone regenerative barrier, I'm not seeing that sequestration because we're buying time with the barrier function to allow that cortical bone graft to incorporate within the native bone. And so we're not seeing that sequestration. But that's a great question, Michael, and I'm so happy you logged on for this. Okay, I think I answered the question about these failing endo teeth. I mean, there are certainly times that we're not going to place an implant at the same time. I mean, it's case selection all the way through. And so it's a case-by-case basis. The barrier capability of a dermal membrane versus pericardium membrane. I have used some pericardial membranes, mainly in periodontal applications, and it's very nice in terms of its handling. It's typically very thin, and I don't know. I have personally performed the dermal apron substituting the dermal allograft with the pericardium. I don't know that the soft tissue thickness that we're seeing here predictably with dermal apron would be replicated in with pericardium. It's an interesting question and something that maybe somebody would want to look at. I typically work in the world of if things are not going badly, I'm not looking to actively change them just to change them. But it's an interesting question. Let's see. There's a question about where the dermal allograft comes from and why not using a xenograft. With the allograft, it could be long-term stability. And this is a question coming from Europe. Well, I would say this. you know, I'm aware of some of these xenografts that are on the market as a substitute for subepithelial connective tissue grafts. And, you know, I don't know that they would handle as well as the dermal allograft. And typically the long-term stability, regardless of what we're using, is coming from the incorporation of this soft tissue graft, be it a autogenous graft, an allograft, a xenograft. And we wanted to incorporate. And so, again, I would not say that this is truly, these thick soft tissues are being achieved not only with the allograft, but the dual zone bone graft beneath them. And it's really a combination. And again, I have to get back to implant position. If you don't have the right sized implant in the right place, there is no miracle that will save you in many of these cases. And so this really goes back again to treatment planning and implant selection and placement. I know in Europe there's been a significant lag in terms of incorporating allografts. It may work with the xenografts that you have available. Duncan, if you want to try it and we can make measurements and maybe work on a comparative paper, I'm your guy. My mentor and good friend Lou Rose just said some very nice things, which he knows mean the world to me, coming from somebody I respect so much. So thank you, Lou. And I think I've gone through all of the questions. So I am very grateful for everybody logging on and asking such great questions. And I appreciate your time. I know this has been a challenge for everybody during these times, and hopefully everybody is staying safe and healthy, and let's get back to work soon.
Absolutely. Thanks, Dr. Levin. It's an amazing presentation.